Good morning and good afternoon, everyone. Welcome to the Leveraging Technology for COVID-19 Adaptations. My name is Jessica Tabler-Mullis, and I'm an Orphans and Vulnerable Children Technical Advisor at USAID South Africa. And I'm joined by my co-moderator, Dr. Andrea Brooks Hansen from USAID Jamaica. The COVID-19 pandemic has profoundly impacted all dimensions of daily life across the world, including HIV service delivery. Across the PEPFAR family, we had to quickly adapt our approaches to continue providing critical services for people living with HIV, as well as children and families affected by HIV. We are pleased to hear from 3 local partners operating in different contexts share their experiences, how they have leveraged technology to adapt service delivery across the HIV continuum of care, all during the COVID-19 pandemic. Our first presentation will be led by Susie Lungo, Regional Director from the Pan American Social Marketing Organization, PASMO, Central America. Our second presentation will be led by Catarina Mapui from Comusanas in Mozambique. Our final presentation will be led by Xavier Biggs from Jamaica AIDS Support for Life. Susie, over to you.
Thank you, Jessica, and good morning to everyone. I'm very happy to share with you today our experience in Central America. Next one, please. I'm going to share with you the different creative solutions and innovation using technology that we implemented in our program identified as Prevention Services Against HIV in Central America. Next one, please. And I would like to start telling you who we are. We are the Pan American Social Marketing Organization, PASMO. We are a local organization with offices in the 5 countries of Central America. PASMO was born just over 20 years ago in the context of a regional USAID-funded HIV prevention program. Over the last 20 years, PASMO has worked closely with donors, including USAID. And as you know, more recently, there has been a strong push from donors to fund local organizations and build, strengthen capacity to implement funds effectively and efficiently. And this means local direct funding to local organizations. So because of all this situation, we became a local organization in April 2020. Next one, please. And in our case, everything happened at the same time. Our 10-year program, the Combination Prevention Program, was ending in 2020. At the same time that a new bid was set to come out for local organizations only. USAID was also auditing us to ensure we met all the criteria for local organizations. I mean, we were going through a NUPAS process, all at the same time that COVID pandemic hit us. And at the end of 2020, also several Central American countries, especially Honduras, Nicaragua, and Guatemala, were impacted by hurricanes and tropical storm, ETA and IOTA. So PASMO staff, along with our target populations, were affected with the destruction of loss of property and goods, including doses of antiretroviral therapy. Transportation routes were significantly damaged, limiting access to certain geographic areas in those countries, affecting both employees and targeted and our populations. So the transition, passing audits, writing an RFA, brainstorming a new strategic plan, all virtually, with no in-person presence or discussions, hurricanes. It has been an interesting challenge, to say the least, but I'm really amazed on our team's capacity to adapt and really respond under pressure to make all this happen. So we were forced to temporarily suspend all field activities and make rapid adaptations to rapidly, to a rapidly operating environment. Next one, please. So the COVID-19 outbreak in our region presented multiple challenges to the implementation of the program's key interventions, especially HIV testing services and linkage to care, showing an impact in the results, especially during Q2 and Q3 fiscal year 20 and the first quarter of fiscal year 21. Many restrictions remain in place, especially the lack of public transportation, curfews, and temporary closure or limited hours of laboratories and comprehensive care clinics, having an impact on the number of effective referrals and linkage rates across the region. And additionally, several team members also acquired the virus, leading to health leaves and other absences. Next one, please. But we survived. However, our program was uniquely positioned to continue supporting people living with HIV and people at risk due to our robust online programming. Innovations such as cyber education. Cyber educators are young peers trained and specialized to carry out behavior change interventions using different online platforms and digital communication channels. They work to identify, reach, interact with, refer, and provide personalized follow-up to users in order to promote the adoption of healthy behaviors and motivate them to seek out health services based on their needs. So in addition to cyber educators, we also implemented virtual accompaniments, at-home HIV testing services, which allowed the program to minimize disruption to services. Next one, please. So, and to achieve all this, we had to rethink, reimagine, and reinvent our strategies and interventions. This crisis, at the end, is also giving us opportunities to innovate, to provide creative solutions to keep people in care during in the pandemic. So we needed to think in a world living with COVID-19, as it will not go away for a long time to come. So disruption and innovation were key. And next one, please. And these were the solutions, how we adapted and responded to the situation. We developed a COVID-19 contingency plan with multiple actions to maintain programmatic interventions as well as the health and safety of our staff. We are constantly reviewing and updating our security plans for each country with emphasis on measures to prevent the spread of COVID-19. We developed guidelines for telework or hybrid models as an option for employees. But I think that moreover, we shifted nearly all of our interventions online, including ongoing online referrals to HIV testing services, virtual accompaniment for linkage, coordination with partners to ensure access to antiretroviral therapies in the case of people living with HIV. And we strengthened the coordination with all partners. And of course, we continue with innovation, launching new products, including HIV testing services at home through the private sector. Next one, please. In practice, these are the results. At a program level, reaching the goals and achieving these results was very challenging. The most relevant result is to highlight the trend. Despite the low results of the first and second quarter of the fiscal year, mainly due to COVID restrictions in March 21, we implemented an acceleration plan with good results, recovering and ending the year with a positive trend in the number of interventions, in the number of referrals, the number of HIV tests conducted, and the number of reactive cases identified. But it is important to highlight the role and the contribution of cyber educators and online interventions. Cyber educators supported their work with a variety of tools, including the different digital brands and their channels. And here you can see some of them. Some fan pages targeted to MSM, some others targeted to HIV, to men at risk, and also working on stigma and discrimination. Next one, please. And in fiscal year 21, we also work to introduce HIV self-testing and PrEP in the region in close coordination with manufacturers and local health authorities to provide more self-care options to high-risk individuals. The demand generation of all these services was done and is done through social media and online interventions, especially through cyber educators. Next one, please. Finally, coordination and working with the private sector through private laboratories offering friendly diagnostic services, including at-home testing. Currently, we are working with 93 testing sites at private laboratories and 10 private clinics offering PrEP services only in Guatemala at the moment. It is important to note that one of these 10 clinics is telemedicine. So we are just starting with that, which will allow us to increase our coverage. Next one, please. So in general, we have been through a lot, and there's still much more to celebrate, as we say. We persevered, and the people who were served did not lose access to the important health services they need. And I would say that for us, participatory leadership, teamwork, flexibility, innovation, and disruptions were key to the success, especially in these times where we're living with COVID. So in general, and next one, please, the challenge is to transform. And next one, please. The challenge is to transform and adapt. So, and this is what we have done in the region, and we continue working with all these innovations and based on technology, most of them. Thank you. Thank you very much.
Katharina, over to you.
Good afternoon, everyone. First of all, thank you very much to this opportunity that you give us to share our work in this local partner meeting. I would like to say that Monasana project here in Mozambique, we are working with the OVC program. Next slide, please. The Monasana project of Viciando Dreams, it's in its stage of the implementation, was faced with the challenge of access to provide the service to beneficiaries due to COVID-19. Physical provision of technical support, supervision, and monitoring to community providers was deficient due to constraints. Difficulties in the triangulation of physical and electronic data affected the guarantee of control of adherence to treatment, viral load collection, and the bidirectional referral of beneficiaries to health and social support services. As we can show in the graphic, the first quarter shows that we reach only 70%, which is much lower than expected, motivated firstly by natural disasters like cyclones, and heavy rains, and later by COVID-19. In order to ensure assistance to positive beneficiaries, the support and assistance mechanisms was created based on the strategy presented here in these works. Like slide, please. The next one. Which methodology and strategy? Another slide, please, about methodologies. Thank you. To overcome the situation of low performance, based on 90,065 beneficiaries in obviously comprehensive population, a descriptive analytical study was carried out based on observation, monthly data analysis, and critical information from the field stakeholders. Taking into account the follow-up problems due to the COVID-19 protocol, specific WhatsApp groups were created to improve remote case management, technical support, and information access, as you can see in the image. That image shows on the right, within the groups, the control sheets for achieving the goals, explanatory audio on the provision of service and technical support, dot exchanges of experiences, coordination meetings, and the tasks for the OHA. Next slide, please. WhatsApp flow strategy in case management. What we did, as you can see, this flow begins with the fixed connection from the linkage facilitators in the Judah sites units, where they share the list of active patients on treatment, extracted from the electronic patient follow-up system that we call CESP. Was list contains information on absenteeism, abandonment, need for viral collection, among other situations. The linkage facilitators, these lists also offer OBC service and refer patient for registration and follow-up through the case management, CCW, assigned to the communities that we call the OBC enroll. Of these referred patients, there is a breakdown into priority subpopulation for the provision of service according to the corresponding needs, from where we will have the general care designated in OBC service. The WhatsApp flow is in each of the phases described above, in which each of the steps taken is reported to corresponding groups of the steps, corresponding groups for the knowledge and monitoring of the entire teams. For example, the number of beneficiaries referred to the health unit in relation to those registered in the OBC program, the number of unregistered, unreached, among others, is shown for all. Next slide, please. Next slide, please. Next slide, please.
Are we on the results and findings slide right now, Katerina?
Okay, thank you. Thank you. As you can see, okay, the results find us. We can see that the use of the WhatsApp is more practical. It also allows field teams to focus more on critical beneficiary and without electronic means. Next slide, please. As we can see, this methodology brought us to K1 to K3 a graph of the results. We grow to 17 to 84. This means that beneficiaries positively registered and supported in the program in relations with the United Health Centers, given the obviously comprehensive target, and we could do something different to these beneficiaries. And if we look at the comprehensive target, 90,065 beneficiaries from 0 to 17 age and their caregiving was possible to achieve results based in the remote case management. Next slide, please. What was done after 6 months, we have to contract more linkage facilitators to this strategy and put all of them in the 21 health units. And these results include the enrollment of beneficiaries with the eligibility criteria in the programs, increase in obviously K population, monitoring adherence, and load collector after sharing the eligibility listed by the clinical partner. Next slide, please. What we can say in this moment, our conclusion is that in general, we can state that even in the presence of the pandemics or other disaster situation, it is possible to provide minimal service and remote technical assistance to obtain satisfactory results using accessible, flexible, and not just physical methodology. Thank you very much. And we can see in the image here our team working, looking the results from the WhatsApp. Thank you very much for this opportunity.
So good morning, everyone. Today I am presenting JASA's infection prevention and control intervention, specifically how we've used that as a response to the challenges with COVID-19. So as you could well imagine, COVID-19, next slide please, COVID-19, the onset of COVID-19 was sudden and significantly disrupted the way in which we provided interventions. Everything that we had come to embrace as normal had changed, and we had to find a way to ensure that we could continue providing services to our clients in an uninterrupted way. Now, a big part of retention is people's ability to move. It is how they are able to access their treatment services, how they're able to collect their medication, how they are able to access laboratory services, etc. And COVID has threatened all of that with the onset of curfews and other movement restrictions. And so at JASA, we wanted to focus specifically on 3 areas with our protocol. One, we wanted to explore how we would use information, communication, and the technology to communicate with clients through traditional media. And we also wanted to expand how it is that we would use ICT within the organization as a communication tool. Tied to that was also the interventions that were specific to how the staff would operate. And so we introduced a screening questionnaire, we made travel arrangements, as well as introduced PPEs and office movement restrictions. Next slide, please. So included in the intervention were a number of things. We wanted to ascertain who were the clients who were adversely affected by the pandemic, and we used the telephone to do that. We engaged them because we wanted to understand who might have lost jobs, who have reduced hours, who had fear of leaving home, etc. And so we could design a client-centered response to that. We then secured a long-term Zoom access and set up virtual appointments for the psychologist, the adherence counselor, and psychologist as needed. The needs assessment followed, and we sought to provide living support and care packages to clients who were adversely affected. And we transitioned all our support groups and the treatment literacy sessions to online mediums. Now, tied to that was the technical capacity of the staff. There is a thinking that because most people were, kind of savvy with using a computer, that the transition was easy, and we found that not to have been so. And so simple things like ensuring that people knew how to share their screen, how to optimize audio when sharing videos, etc., was a part of what needed to be included in it. And as we onboarded new digital systems to manage clients during the pandemic, we also had to ensure that staff were capable and competent to manage those changes. There was also the need for reallocating financial resources. For example, resources that were once earmarked for travel stipend support had to be rerouted to things like phone cards to provide call credit and data. And also there was a reimagining of traditional interventions such as direct observation therapy that we now moved to virtual platforms such as WhatsApp. Next slide, please. Let's zero in a little bit on the teleconsultation and virtual support group engagements. Now, we established from the previous slide that we identified people who were adversely affected, and we would have gone through a process of looking carefully at who was scheduled for what appointment next. And we use that to ensure that clients were prioritized and offered services based on their due dates and the specific services that were needed. The provision of call credit was an interesting one, because when we introduced that solution, it became a solution that needed sort of to be widespread. So it was not just to the clients only, but we also needed to ensure that the psychologists, the case managers, and the adherence counselors also had adequate call credit and data plans to have the engagements in an ongoing kind of way, so that when we schedule clients, they would have been able to access the sessions. Now, what was particularly interesting about, for example, the virtual support groups is that we saw an uptake in the access to those services as clients no longer had to schedule travel time to and from the sessions. They were now able to join virtually as long as they were in a space that allowed for them to do that. And so persons felt a little bit more comfortable, and we were able to now make those schedules in irregular hours, late evenings, early mornings, and on weekends as per the demand of the clients. The video callings were also an interesting one, simply because they added a sort of personal touch. So yes, you might not physically be able to see someone in front of you, but the video calling allowed for you to engage and recognize that the person that you were talking to was real and present. Next slide, please. So what exactly did this do for us? It saw our numbers being retained. We, up to September 21, had managed to retain just under 90%, 89.2% of all the clients we had in care. So let's start with the top one on register. Please note that for the entire period, JASL's register did not stay static. Between March 2020 and September 2021, we still added just over 100, roughly 115 clients to our register. If you notice, between March and September, there was a slight dip. This, of course, was due again to the onset of COVID-19 and us needing to find a solution for that. But beyond that, with the interventions rolling, we were able to maintain and improve retention over time. You'd have also noticed the same happening with the viral suppression dip. We would have the reallocation of the viral load reader in the Ministry of Health and Wellness caused some challenges for us. But again, because we were able to stay on top of that with the ongoing engagement of the clients, bringing people in, the usage of a centrifuge to uptake blood whenever it is that they would have come in, we were able to also retain clients over time. Next slide, please. So how exactly are we going to be keeping these things moving forward? Because the pandemic is ongoing, we are going to have to revise the protocol as needs be. Again, the protocol speaks to how we communicate. It speaks to the systems that we have introduced, and it speaks to things, for example, like how we were split the team in two to ensure there was no cross infection in the event that someone received a positive COVID-19 result, etc. And so we will continue to make updates to the protocol as the pandemic continues. This no doubt has been a little bit on the expensive side, not in terms of the virtual components, but because of the levels of support we've had to provide to people, in particular the living support and care packages. A number of people continue to be significantly affected by the ongoing pandemic and still have lost jobs, have lost hours. And so we have a mission to continue providing them with certain levels of social support to ensure that they are not further adversely affected. The ongoing technical capacity building of staff is something too. We believe that if our team has the tools and competencies to reach out to our clients, they will continue to do that with a particular quality. And so we'll ensure that that continues to happen. And of course, the expansion of our social media and mass media campaign is dear to us. I want to plug that in particular because of how we would have rolled out a series of campaigns over the last year, such as our Come to Care, Now is the Time, and Do It Safe promotions that have helped us with messaging in the general spaces so that people are aware that now is the time to get on treatment so that persons can come to care if it is that they are out of care. And of course, for those who continue to have sexual engagements, that they do it safely. Now, one of the things that Justice strongly believes in is the integration of things that we have found to be successful. And so we believe that the ICT protocol is one such interventions. And so we will be introducing certain aspects of it in an ongoing kind of way. So the telemedicine engagement, for example, is one engagement that we will definitely be keeping a hybrid version of, where clients will alternate between that. They have the option of a telemedicine session and a regular session alternately. And we will also be maintaining components of the virtual support and treatment sessions to ensure that clients have ongoing access to the services that we provide. So that was the IPC, the Invention, Prevention, and Control Protocol in a nutshell. I'm here to answer your questions. Thanks.
I do want to thank all our presenters for the excellent presentations. And I would want to allow for the answering of some questions as posed in the chat. And so for Team Mozambique, the question from Falakis in USAID is, how did you ensure confidentiality of personal sensitive information while using WhatsApp for reaching out to beneficiaries during COVID? So I'll turn it over to you. And I think that would be you, Katerina.
Thank you very much. The WhatsApp groups are organized by specific groups. We have a groups of linkage facilitators, groups from the CCWs, groups from the technical persons. And then from this situation, all the specific groups, when you call about the CCWs that working with the management cases, they sign the confidence protocol. From the protection, child protection, and the confidentiality information. About the information of HIV, all this information we can find in the unity health centers. They are in the health centers, and the case management don't have accessible from the content from the disinformation. So they have to give us the numbers, how much children they are given, how much patients have problems, how much things that they have to do in that moment. Thank you very much.
Thank you so much for that, Katerina. So I think in essence, Katerina was saying that consent was given for this personal and sensitive information to be shared. So Xavier from Jamaica Aid Support for Life, the next two questions are for you. One is the sharing of the tools if they are available. And the second is, how did you ensure, or how did Jazzle ensure those without access to the virtual platform were equally reached with critical services during the COVID lockdown? Over to you, Xavier.
These are two very, very good questions. So let's take the tools. So we are willing to share components of the tools. All the tools that were developed in-house. And so, yes, we can share them. You may have to tweak them to your unique situations, but please reach out to my team via email, and we'll be happy to see what's possible in that regard. Specific to reaching everyone. Now, the beauty of the intervention is there are two things that happen. We would have done the needs assessment component, and so we would have determined very early who had access and who didn't. And in the reallocating of the resources for call credit and data, we would have responded to significant specific vulnerabilities that people had around affordability of these pieces. And so because we were funding the call credit and the data, that resolved that component as long as people had a compatible phone. It's also important to understand that these interventions did not completely replace existing interventions. They supported us. And so there are individuals who would not have had access to a cell phone who were scheduled in a routine kind of way to access services. We also did the Zoom platform with password protection, etc., to ensure that we were able to control who would and wouldn't access the spaces. And we set up the rooms for long-term periods so that the psychologists and all who needs to use the space would be able to engage the clients on demand. I'm hoping that answers your question. If I can expand if needed.
Thank you so much, Xavier. I am seeing another question that is posed for you, and it reads, were the clients able to afford to buy smartphones used for WhatsApp, or did your project donate smartphones to all clients who could not afford to buy them? And so I'll turn over again to you, Xavier.
So that's another interesting question. But interestingly enough, the truth is smartphones have become a lot more accessible than in times past. So not everyone has an iPhone X, 11, 12, or 13, but people have been able to access through our local suppliers much cheaper options, be that Alcatel or DL devices, or even low-end Samsung devices. The fact is communication in our space now has sort of become second nature, and everyone is on WhatsApp. And so even if they don't have a premium quality cell phone, they do have access to a phone that allows some amount of smart engagement. So no, we did not provide cell phones, but where possible, we provided a space that they could still come in and become a part of a virtual group if they wanted to join others from here. And also just generally, communication access has become a little bit easier with much options available to clients at a low cost.
Thanks, Xavier. I actually have the same question for Katarina. Katarina, it would be great to hear how Kamisanas beneficiaries were able to, or how did you access beneficiaries that did not have access to phone or data? How were you able to reach them through WhatsApp? Or did you reach those through home visits?
Thank you. Thank you very much. We don't buy a smartphone to nobody. We can't do it. So for these people that doesn't have a smartphone, we prioritize them in the home visits. We do like remote. We don't use the remote case. The leakage facilitators go to their homes and do the visits. We don't give the smartphone to these people. Thank you very much.
Excellent. Thank you, Katarina. And back to you, Andrea, with the next question.
Thank you, Jessica. And there is another question, Xavier. You are the man of the hour. Which platforms did you use for the support groups? Was it just a text sort of platform? Did you have audio or video meetings involved? And so over to you again, Xavier.
So the primary application that we used was Zoom, but we purchased premium Zoom that allowed us additional controls and extended sessions. So the sessions were video and audio friendly, mostly hosted on Zoom, but we had the capabilities to set up waiting rooms that would allow us to control who would come into the rooms and when. We also would set up the rooms long-term so that they're available in irregular hours. So yes, we had both audio and visual components. There were text engagements. So for example, we spoke about there were text and WhatsApp engagements. So we spoke about the direct observation therapy. That was a quick video call on WhatsApp. And we did have text engagement with individuals. But again, sometimes a lot gets lost in text translation. It's how people might interpret tones and intonation and all of that. And so we have found that phone calls, video calls, and Zoom sessions provided better opportunities for engagement.
And Xavier, I'm asking you not to leave. We do have another question for you before we go over to Susie. And it's how were you able to ensure quality checks of service through virtual case management? And how did that virtual case management help in contact services for viral load sampling?
So again, the virtual engagements were a hybrid model and supported us in engaging the clients in an ongoing kind of way without replacing the need for physical engagement. So for example, a stable patient who would probably just need a check-in would have the option of using a telemedicine session to engage with the physician. And a special form was created. Key questions were asked throughout the engagement, and that form completed. No two back-to-back teleconsultations were allowed. And so if you have a teleconsultation, no, your next visit must be in person. Now, relative to things like the uptake of viral load, this wasn't so much a COVID response, but JASL this year introduced a centrifuge in each of our sites. Why is that important? Before now, everyone who needed a viral load associated with that site would need to come on a specific date to have their samples taken. With the centrifuge that was introduced meant that people could come in any day of the week, we do the blood pull, and then we were able to send that off to the lab. Now that allowed us to expand the number of days that people would come in, reduce the crowding, the prospects for crowding. And so no, we did not replace physical contact. We just introduced these measures, one as a hybrid. So there was two things happening, but two, to better space how people would physically come into the sites.
Excellent. I do think that response should have answered the question. And so, Susie, this next question is for you. Jazzle would have touched on it, but we do want to hear about the opportunities presented by the COVID adaptation outside of the pandemic. And do you believe that these adaptations are sustainable moving on in the future? So over to you, Susie.
Thank you. Yes, definitely we think that all these adaptations are sustainable. Actually, we initiated with cyber educators like 6-7 years ago. But during COVID, all that platform and all that team really grew. Right now, we have around 30 cyber educators through the region working online and using multiple channels, including WhatsApp. including, Facebook, Instagram, TikTok, for example. And all these interventions are cost effective, and also in terms of security allows us better to reach, especially in some countries where this is an issue, to implement field activities, to outreach online and provide follow-up online, also give us those advantages. So in general, we think it's sustainable. We are expanding cyber educators methodology, and we have been able to support and train Global Fund implementers. So more and more moving to online, but it's important to mention that it's not just to move, but like to combine the strategies. So those mixed strategies, because we still have field activities, but combined with online. So thank you.
Thank you. And over to you, Jessica. You may have a question.
Thanks, Andrea. I actually have a question for all of our presenters. I was wondering if you could elaborate on how you've been able to provide supervision for those cyber educators and or the caseworkers providing remote case management through WhatsApp. And Xavier's, your case, tell us a little bit more how you're building the capacity of your frontline workers and providing supervision. So let's start with Susie, since you're on camera. Then we'll move to Katarina and then Xavier.
Sure. Well, we have multiple ways to supervise. We use a unique identifier code to track. So we are able to track since the very beginning, since cyber educators initiate the outreach. So all the interventions, then we send virtual vouchers for all the referrals. So we track the referrals, the number of referrals sent, the number of effective referrals, and then we cross data coming from the private labs or the testing sites with our own data. So we have a strong monitoring system, and that is key. In addition to this, we also have satisfaction interviews, so we get feedback from users, and we also use the social media metrics, so we know when people are using the different social media tools, and we still have the traditional supervision. The way we supervise field activities exactly the same. We also supervise online activities, accompaniment with the cyber educators, checking conversations and interacting with them through all this process. So monitoring is key for these interventions, and crossing data. I think those are the two main conclusions. Thank you.
Thank you, Susie. Over to you, Katarina. Tell us about your supervision model.
Thank you very much. First of all, I would like to explain about one question. Within the M&E sector, we have a database matrix which the viral loads collection is controlled, and reminders are sent to eligible users from collection. Case managers through this matrix make contacts with the respective beneficiaries. And the supervision of case management is physical, but with few contacts. Through the data they send on WhatsApp, we do the physical verification, but reduce the numbers of meetings. Thank you. And we use more spot check to this case.
Over to you, Xavier.
Yeah, so so there are a couple of ways. So if you remember our last slide, I think the most potent determinant of the effectiveness of the interventions would be the number of clients who would have been moving towards viral suppression. And within the last year, we'd have added close to 200 additional clients reaching viral suppression over the last 18 months. And so as a standalone, there is that increase in the quality of health outcomes that we would have experienced. But at a systematic level, there are a number of things that happen. So the care provided at JASL is a part of a broader team experience. And so activities like case conferencing, conversations, and all of that are a part of the mix. And so when we have these engagements with clients, they are not done in isolation by an individual rep, though the individual rep might have provided the service, but the conversation around getting the client to the desired health outcome is a part of a broader case management and case conferencing conversation. And those happen weekly with the medical director. Now, outside of that, there is the capacity building component of the model. We continue to ensure that the teams have skills and competencies to effectively execute their function. And because of the stringent reporting mechanisms that exist within HIV management, you get to see beyond the virtual engagement what people do. So there's a treatment, care, and support report. There are psychosocial engagement reports for the psychologists and adherence counselors. There are quantitative reports that measure or monitor the movement of people in and out of treatment through indicators like ML and RTT, and just a bunch of processes on the back end. Also, one of the things that we have done as a part of this is that we've set up tons of tools on Google Drive that allow the different sites to plug in their achievements, and we cross-reference those achievements with the treatment services information system that is available in Jamaica. So there are multiple points for us to see the efficacy of the interventions. And so far, I'm happy to report that they've all been pretty successful.
Thank you. And so this is next question, and it will be our final question for this session, is for all presenters. And it relates to the challenges on internet access, especially in rural or remote areas. What was the ability of the healthcare workers like in applying the technologies in service provision with regard to the critical shortage of healthcare workers, especially in maybe the NGO setting and the faith-based organization health facilities? And so I'll turn it over to Jazzle first, knowing that you are indeed a civil society organization, and then we'll take it backwards to Katerina and then finally Susie. Over to you, Xavier.
So the truth is the internet quality over the last year has deteriorated. In fact, it might be very, very horrible in some places, but it has not been horrible to the point that we've not been able to get around it. So for the most part, there are certain peak daytime hours that present as problematic when the kids are going to school from home and people are working from home. And so there's a particular burden that comes onto the system then. But we find that earlier in the mornings, early afternoon and late evenings have been pretty reliable when it comes to meetings. That is not that we've not applied a science to that yet, but the team has kind of found times that work for them and to get around or navigate the connectivity issues that we've come across over time. The truth is, when it comes to, like, for example, so we've not had a staff shortage situation in our model, simply because, well, a couple of things. Not 100% of the staff employed to Jamaica AIDS Support for Life are full-time. So our doctors, for example, are sessional, and we sometimes pull in sessional nurses and sessional psychiatrists to provide support to us. How we've responded heavily to that is scheduling. So JASL has, again, early morning options, late evening options, and weekend options to ensure that, one, we are responding to the specific needs of the clients in the variety of ways that it appears, but also to ensure that we're able to provide service in an ongoing kind of way, regardless of what the service provider nuances might be. Over.
Thank you, Xavier. Over to you, Katerina.
Thank you very much. Really, in this area, we have problems. It's difficult to work because of the internet. It's a big problem for us. We prioritize in this area the visits and the physical activities, the spot checks, to look at how we can move and another things challenge because we can have different problems from the net. But even when we look at that have got a good net in his place, have got a problems to manage the smartphones. About managing smartphones, we did videos that we share to them how they can introduce the data collection, how can they if you have any problems, how we can help them in these places. But the internet really, it's a very big problem to have. Thank you.
Okay, and in our case, well, indeed, there are challenges with internet, and we can see that in our region, the differences between countries. But I think that the response is the use of a mix of strategies, and so because we don't use only WhatsApp, we also use other tools that can help us, and we still implement in the field. In general, there are more and more, and segmentation would be the second response, because we know it's exactly the profile of the users that have more access to internet, youth, for example, or some socioeconomic levels between MSM. So those are more reached through online tools, because they have more access to internet and to the devices and all that. And we still implement in the field and with other methodologies to the other groups. So it's the combination. And we are more recently working, identifying that also indigenous groups are also in social media and can also be reached through cyber educators, but adapting the messages and the tools we use. So I think that those are the different strategies that we use. Thank you.
Thank you so much to all our moderators and our presenters for the excellent presentation. We had some good key takeaways today. One is that the ability to transform and adapt the services, despite many challenges that may come at you all at once, is needed. Also, accessible and flexible services can be provided via remote technical assistance, even in disastrous situations. And finally, that the expansion of the ICT platforms to continue services across the continuum of care is feasible, it is sustainable, and therefore we need to reimagine how services are delivered and also redirect budgets accordingly. I do want to thank everyone for taking the time to attend this session. It was indeed beneficial.